there's just so much.
You're listening to a Mamma Mia podcast.
Australian women, welcome to your full body health check. I'm Claire Murphy. And for me, giving birth was part awful and part amazing, because there's one midwife who I questioned whether being a midwife was actually her calling or not, and one who I wanted to bundle up and take home with me, and she was just incredible and like captured things before things, even... You know what I'm talking about, right?
Gave it a bit of a wipe.
Yep, wiped up, cleaned me up, didn't even see it. Amazing.
And I'm Dr. Mariam, and some days I like to think of myself as a birth Olympian. I carried twin boys all the way to 38 weeks.
Can we just mention, if you have not seen Mariam, you're not a big person, so for you to have two actual human beings growing inside of you must have been insane.
Yeah, so I carried them to 38 weeks and delivered them out of my vagina.
Oof.
Each weighing over 3 kilograms. So if that doesn't qualify me as a legend, I don't know what does.
You got a medal, right? Surely you got a medal or something.
Maybe it's the fact that I pee every time I sneeze. Either way,
That's your thanks for
I earned my stripes.
That you did. Coming up today, we are getting down and dirty with the final part of the pregnancy process. We are, of course, talking about giving birth, from what really happens to when you're induced, and why structurally some things may never be the same again, and how to advocate for yourself in the delivery room when you're not maybe in the greatest frame of mind to do so. We're also going to do a quick consult for Shelley today. She's been using a menstrual cup and is suspicious that it might be causing some very painful and burny issues. But first up, it is med school time, and yet another fun fact about our uterus that I have never heard before.
Let's do it.
Welcome to med school.
I'm not sure how much I'm enjoying the fact that I'm finding out things about my body as a fully grown-ass woman that I didn't know before. It is eye-opening. So when you have your period, and the lining of your uterus comes out in bits and pieces. It's not just all coming out together.
Out in chunks.
It's over 4 chunks. Is such a descriptive word. It comes out with blood and other fluids and bits of the lining, 4 or 5 days worth. In some rare cases, instead of the tissue breaking down and coming out in quote-unquote chunks, the entire uterine lining comes off at once and pushes itself out.
Jeez.
It is called, I've just found out, a decidual cast, and it often comes out in the exact same shape as your uterus. So I've read some people's descriptions who've had this happen to them. Some have said it is fleshy and pink. Others said shiny, shaped like a light bulb or a pear. It's also associated with severe abdominal pain. Mariam, this is a whole other level of period I didn't even know existed.
Yeah, so your uterus lining, the endometrium, that thickens every month and it's preparing for a fertilized egg. So fertilization doesn't happen, the hormones drop, and then that lining will shed. Voila, you get your period. Usually it's a steady process over a few days, but this decidual cast thing, so it's rare, but it's real. So think of it like your uterus giving you a full house clean instead of a gentle tidy up and shedding the entire lining in one go, sometimes shaped like a uterus itself. So can be shocking and painful, often with cramps way worse than your usual period. It's not something to ignore. If anyone experiences this, especially if you're having severe pain, it's a good idea to chat to your GP just to exclude other conditions.
Shall we move on? Okay, the big day has arrived.
Let's do
Mariam,
it.
It's time to birth our babies. So let's get this checkup underway.
It's time for the checkup.
Now, look, I had a friend who is due to have her baby in the not too distant future, and she said to me, what was your experience like? What could I learn from you, and what would you have liked to have known before you had your child? Honestly, I said to her, look, I could tell you all the things about my experience and how I would have done things differently. But seriously, there is really nothing anyone can say to you or you can read in a book or learn off a video that will fully prepare you for what is about to happen to you, because so many different things can happen, right? And my experience is different from your experience,
That's
Mariam.
right,
It's different from everybody else's I know. But there's a few basics that we can agree on. So can you talk us through
Let's do it.
this first part, right? So let's say the baby is coming out vaginally. You've gone into labour without needing to be induced.
Yeah.
What are the stages of birth and what is your body actually doing when you go into labour?
Okay, so when your labour kicks off naturally, so that's no induction, your body is basically gearing up to welcome the baby into the world. So there are 3 stages. So the first one we say is early and active labour. This is when your uterus starts contracting and it's coming often, and the contractions help to soften and thin the cervix, and that's the neck of the womb. The early labour can feel a bit like mild cramps or a backache, and that's when your cervix is dilating from 0 to 6 centimetres.
Just get a ruler and look at how big 6 centimetres is.
Gets bigger. It might be slow at first, and that's totally normal. Then active labour begins and the contractions start to get stronger, they get longer, and they get closer together. Your cervix continues to open up to about 10 centimetres, so get a ruler now, and that's fully dilated and ready to go. So come stage 2, that's pushing and the birth. So once you're fully dilated, your body is going to tell you it's time to push. The contractions help push the baby down that birth canal. You'll feel this powerful urge to push. It feels kind of like an urge to shit, really.
It really is. Like, don't go to the toilet if you're in late stage labour.
That's why a lot of females deliver babies in the toilet. Anyway, your midwife or doctor will guide you through this. The baby's head will crown, and that's when you can see it at the vaginal opening. And then with a bit more effort, your baby is born. It's a huge moment of teamwork, but really is it teamwork? And yeah, it's between your body and your supporting birth team. So then comes stage 3, which a lot of people don't know about, which is delivering the placenta. Mm-hmm. So after your bubby's out, the uterus keeps contracting to deliver that placenta, the afterbirth. It might feel like another contraction or 2, and it's an important part of finishing the process. So
did you look at your placenta after it came out?
Yeah, I did.
I just was fascinated.
It's an organ. It's like you made this organ. It's insane.
It looks like a meat pancake.
It looks like an alien.
Yeah, and then it has like this incredibly stretchy membrane, which you can't see when it's just sitting there. And then my midwife goes, check this out, and lifted it up. I was like, whoa.
It's insane.
That's crazy.
Yeah, and then so you'll deliver that placenta. But yeah, every birth is unique. The timing, intensity, experience vary widely. There's a no one size fits all, but essentially they're the 3 stages.
And do people do that thing where my water's broken like we see in the TV shows and there's you're standing in a puddle?
Great question. So no, your waters don't always break first. In fact, for many women, labour starts with the contractions before the waters break. Mm-hmm. So the water is the amniotic fluid that is in the sac that cushions the baby in the womb. And sometimes, yes, that will rupture on its own during labour. Sometimes for some people might happen before labour. And if it does, they will monitor you as well. But yeah, so it's not that dramatic gush that you see when they're shopping in the...
They just stare down at the floor and there's a clear
the baby's
fluid.
Coming. No, it's not always like that, no.
Okay.
I think only 10 to 15% of females experience that.
Yeah, right.
Yeah.
Okay, so as we've mentioned, there's a ton of different scenarios as to when your baby comes out. But what about caesarean, not emergency? Mm-hmm. Because that's a whole other different thing. Elected C-section, you haven't gone into labour at all at this stage. What happens when you're cut open to get your little one out?
Yeah, okay. So you'll usually be given a date. You'll have clear instructions about what to fast, what to bring, when to arrive. You get to the hospital, you'll be admitted, and you meet the team caring for you. That will include your midwife, your anaesthetist, your obstetrician. They'll go through your medical history, your birth preferences, and what to expect on the day. So you might be able to choose what track is playing. And for the procedure itself, you'll receive something like a spinal block. So that's an anesthetic that kind of numbs you from the chest down. You'll be awake, but you won't feel pain, just a bit of pressure and movement. So once the anesthetic is working, they'll make a small horizontal incision on the lower abdominal, just above the pubic line, and the team works with great care. And usually within about 10 minutes, baby is out. You might feel a bit of sensation and tugging as they get the baby out.
Can we be clear though? They're not just cutting open skin.
No, they're cutting all the layers down.
There's seven layers. There's muscle and there's subcutaneous thingies going on in there.
Yeah, so a lot of people just we just cut open the baby's right there. That's the baby's deep down. A lot of skill with C-sections, and they come with their own risks as well. So I hate it when people are like, C-sections are the easy way out. They definitely are not. So so once baby is out, baby will be checked by the pediatric team, and when possible, placed on your chest for that skin-to-skin contact, which is super important.
Which is the moment you go, holy shit, look what I made.
Exactly. The moment is deeply emotional and connecting, and it is powerful as any other birth experience. The remainder of the surgery involves delivering the placenta and carefully closing each layer of tissue that we've mentioned. You'll be taken to recovery where your baby stays with you if both of you are well, and you'll be monitored closely. I just wanted to say an elective C-section is still a birth. It can be safe, empowering, and emotionally significant. Choosing or needing this path doesn't lessen the strength or meaning of your experience. It's simply a different way to meet your baby.
Hear, hear. Okay, so those are the two most basic ways of baby's arrival, right? But what about all the others? So how do we plan for something like an emergency caesarean or having to be induced because your baby's refusing to come out like my small human did? Or what if they come like way too early? How do you possibly prepare yourself for any and all of those scenarios?
Look, Claire, the truth is you can't plan every detail, but you can prepare your mindset and the support around you. So birth, we know, is unpredictable. Sometimes your baby doesn't get the memo about your preferences or your birth plan. Maybe your waters break, but your contractions don't start. Maybe your baby is a breech or distressed and you're suddenly told you need to be induced for medical reasons. Maybe labour is progressing beautifully and then it stalls and things change suddenly.
Umbilical cords are also unpredictable things. They might be wrapped around places that they shouldn't be.
Exactly. And these scenarios are common and they don't mean you failed or you've lost control. So what helps? Education. Knowing what an induction might involve, understanding when and why an emergency C-section might be recommended helps you feel less blindsided. Learning the signs of preterm labour or what happens in NICU, for instance, means you're not navigating in the dark if your baby does come early. But it's not just about information, it's about flexibility, informed consent, and having a team that you trust around you. That's so important. It's about knowing you can ask questions, you can say, stop, just give me a minute, pause to take a breath, and still be an active participant in your care even when the plans change.
How did you as a doctor speak up for yourself in this process? Because so many of us struggle with this. In fact, I was just reading a story about a woman who had a showdown with her OB in the delivery room because he was like, I'm going to check your cervix now. She said, no, thank you, I'm not ready. And he said, I'm going to do it anyway. And luckily in that situation, the midwife stepped in and said, no, she's not ready at this point. Please, doctor, continue your rounds, come back later. But how do you deal with a situation like that?
God, that's infuriating hearing that story. And I know exactly how tough it can be to advocate for yourself when you're lying on an exam table, you're vulnerable, and someone in a position of power, you know, whether that's a doctor or a midwife or any other health professional is pushing ahead without your consent. When you're the patient, especially in pregnancy or labour, your power can feel really fragile. And I had moments myself personally, even as a health professional, where I had to speak up, where I felt things weren't sitting right or I needed time or space or just someone to explain what's happening. And what helped was reminding myself that my body isn't a clinical case. I'm a human being. I have feelings, I have fear, and I have a right to be involved in every decision about my body. And in situations like the one you described, this is a clear breach of consent. Full stop. No healthcare provider should ever perform a procedure without informed consent. And if you're not ready, that's the end of the conversation. You're allowed to say no. You're allowed to ask for time, and you are definitely allowed to request for another healthcare provider if someone crosses that line. I always tell patients, it's your body, your birth, and your boundaries. It doesn't matter who's in the room. You deserve respect, clear communication, and consent at every step. If that's not happening, bring in a support person, ask for a second opinion, and if you feel unsafe, escalate it. And if you can't advocate for yourself in that moment, that's why a support group is so important, and that's why we've got midwives and partners and friends. So if you can't have that conversation with that person in that position of power, definitely speak to someone you can trust.
Sometimes you need that person.
Down.
Yes, please. On the way, a quick consult for Shelley today. She's a little bit sus on her menstrual cup, but next we catch up with obstetrician Dr. Noori and midwife Betty Holland to talk through a bunch of stuff we should all know before we hit the birthing suite, from hospital v home to vaginal v Caesar, drugs or no drugs. There is a lot to unpack. So as we've mentioned, giving birth is such a personal experience, but it's one we do with a team around us. So that's whether you choose a home birth with your family and a midwife or a hospital birth with an OBGYN. There's a lot of things we can consider as we create our birth plans, which despite it being in the name, often do not go to plan. So we asked Dr. Nargis Noori, an obstetrician and advanced gynaecological surgeon, and Betty Holland, who's a clinical midwifery specialist from Women's and Newborns Health at Westmead Hospital, about all the things we need to prepare, starting with home birth v hospital and what we need to know before we make that choice. So let's kick it off. The first question is home birth v hospital birth. What do we need to weigh up beforehand? Betty, what are your thoughts on that?
So we do have some evidence that suggests for low-risk women with a registered midwife supporting them at home that there's good evidence that they have safe outcomes with a home birth. I think access to publicly funded home birth is really tricky for women. And so we know some continuity of care models do offer publicly funded home birth, but we still follow hospital policies, which means that you need to be very low risk in order to get into them. And privately practicing midwives also offer home birth, but there's a cost associated with that, which isn't always feasible for women. So I think we need to think of safety in birth as multifactorial. So it's not just physical safety, and we've got a big emphasis on that in hospital births, but we want to think about your emotional safety and your spiritual safety. And for a lot of women, they will give birth in a hospital. And my main thing with that is just thinking through, how can I make this space feel safest for me? How can I have adequate supports? And how can I feel my oxytocin flowing in a hospital context? And there's no right or wrong. So different things will feel safest for different women.
Can we talk about the caesarean versus vaginal birth? Because this seems to be a pretty hot topic and people have some very strong opinions on it. Can we talk about the pros and cons of both?
This conversation does tend to come up a lot during antenatal care about what the best way to deliver a baby is. And the gist of it is there's no best way, there's no right way. Everyone's different and it really does need to be individualized. It's really important that families are provided with all the information so that they can make their own best informed decision for themselves and do something that they're going to feel safest and empowered during. So both vaginal and caesarean section births do have their advantages and disadvantages. Namely, with a vaginal birth, I guess it does obviously aim to foster a closer bond between mother and baby, especially with initiation of breastfeeding and things like that. There's definitely a quicker recovery period associated with it, unless you have a very, tricky vaginal birth, which can also happen. And it does give women a lot of options in labour when it comes to making decisions for themselves and taking more of an active role, which a lot of people value. There are some disadvantages. So some vaginal births can be very long, can be very painful. You might not have the ideal vaginal birth that you initially was hoping for. And that can put a lot of women and families in a bit of a negative headspace when that happens. And so then you've got things like planned caesarean sections, which a lot of families prefer because it's a little bit more of a controlled setting. But having said that, caesarean sections also come with a lot of risks, surgical risks, whether that be infection or bleeding or accidental injury to other things. And so it's really important that you're given all this information so that you can make the best decision for yourself, because ultimately there is no right or best way to do that.
I've just had a colleague who went into labour 5 weeks early and there was no signs that was going to happen. It came very much out of the blue for her, but I'm interested to find out what kinds of things causes someone to go into early labour.
So early labour, preterm labour, is basically when you go into labour before 37 weeks of gestation. A full-term pregnancy is 40 weeks. And there's a lot of conditions, we call them risk factors, that could potentially increase that risk of that happening. So some possible scenarios, and everyone's a little bit different. So if you've had previous preterm births, you are at increased risk of having another one in the future. If you've been diagnosed with conditions like a short cervix in pregnancy, some infections, like even a urinary tract infection around that time. If you've ruptured your membranes early, there's a higher chance that then you'll naturally go into labour. There are other conditions like fibroids in the uterus. If you have multiples, so like twins and triplets, you're very likely to go into preterm labour. And then there are other little things like smoking in pregnancy and low birth weights and things like that. There's some evidence for as well that does increase your risk. So a variety of different scenarios, and you may not even fall into any of those. Sometimes it just happens as well.
Can you just give us an idea of what it means to be induced and how that experience could differ compared to if you were to go into labour naturally?
An induction of labour basically is when we have made a recommendation that we need to start your labour artificially. And that can be for a few different reasons. So one of the most common reasons is that you've gone over your due date.
We've overcooked it.
Exactly.
Yeah.
So we have a discussion with you about the benefits and risks, and we say, all right, let's get this show on the road. There are typically two sort of steps to an induction of labour. The first step is making sure your cervix is ready, and we call it ripe or favourable. And it just needs to be open enough that we can break your sac of waters. So break your waters with a little amni hook. And so we want your cervix to be at least sort of 2 to 3 centimetres open for us to do that. Different hospitals have different ways of preparing the cervix for an induction of labour. It might be something like a balloon catheter that's inserted into your cervix, or an oral pill, or a little pill that's inserted into your vagina as well. And so that typically happens the day before an induction is sort of scheduled in. And then you come into the birth unit, you have a drip pop in your hand, and then we start a hormone drip. And that hormone drip contains a synthetic version of oxytocin, the love hormone, or the hormone that causes contractions. And we basically titrate that hormone drip to cause contractions. And so we sort of keep increasing it until we're happy with the contractions that we're getting. In terms of how an induction varies from spontaneous labour, we are sort of controlling it all. And so it tends to be much more intense. It tends to be 0 to 100 much more quickly. And in terms of the physiological aspect of it, we are sort of asking your body to do something that it hasn't done yet by itself. And so we know that that means we've got a higher chance of needing more pain relief, and we've got a higher chance of maybe needing some assistance in terms of getting the baby out.
Let's talk about birth plans, because despite it being in the title, things often don't go to plan when we're having babies. So how do I make sure that things don't happen that I don't want to happen?
So I think the first thing to remember when we're having this conversation is that as a pregnant woman, you have a right to informed decision-making and autonomy over your body, including your birth preferences. And so you have a right to ask all of the questions that you want to ask and have them answered by your healthcare provider. And you have the right to give informed consent and to refuse recommendations that are made as well. So just to start with that, I think this is where antenatal education is really, really important for both yourself and your birth support, so that you're aware of all of the different sort of options or all the different things that could happen and what your preferences are for each sort of different scenario. The other acronym that I really sort of like is BRAIN, and that sort of helps you to break down your thought process or your conversation with your healthcare provider. And so that's considering benefits. What are the benefits of this recommendation? Risks? Are there any alternatives to this? What is my intuition telling me? And then I need more time, or what is the time frame for making this decision? And so that can sort of help guide and prompt the conversation. Yeah, I think that you have a right to ask all of the questions. It's your body, and nothing should be done to your body without you knowing ahead of time. And I think that having these conversations with your birth team before it gets to the sort of the intense end of birth is really important, so that they're aware of what you do and do not want in an ideal world. And that will sort of affect the way that they care for you and communicate with you as well throughout the process.
What are the different options for pain relief to use during labour, and what do they actually do to you and to the baby as you take them?
We think of pain relief options in sort of two ways, I think, when it comes to labour and birth. So we've got non-pharmacological things, which are things midwives love to sort of start off with. So this includes things like water immersion, so having a nice warm bath, getting in a nice hot shower is amazing for back pain. TENS machines, and so these are little machines that you pop particularly on your lower back that send electrical signals from the nerves on this skin to partially block the pain signals to your brain. Things like meditation, mindfulness, positive affirmations, speaking words out loud are really useful non-pharmacological pain relief options. And then when it comes to pharmacological options, this means like medication-based pain relief. We've got things like the nitrous oxide gas or the happy gas. It encourages the mum to focus on her circular breathing, and it just can get rid of sort of some of the intensity of the contractions for women. So a lot of women really like happy gas. We've got morphine, which is an injection that we can give. Morphine does cross the placenta, and so we know that morphine can make mum have a nice rest, and it can also make the baby a bit sleepy as well. So we don't want to give morphine at the pointy end of labour or when the baby's going to be born, because it can mean that they're a bit sleepy when they're born and might need a little bit more help initiating breathing as well. And then, of course, we've got the epidural, which is where we administer medications through a catheter in the epidural space, which is in the woman's lower back. These medications do cross the placenta, but it's in a low concentration that's considered safe and with minimal impact on the baby.
I guess something, as someone who's had an epidural too, that I didn't quite understand was that you will have to be catheterized if you do have an epidural, right? So you won't be able to hop out of bed and go for a walk once you have that epidural because your legs aren't working so great and you don't have great control of your own bladder, right?
That's right. Yeah. That's one of probably the main pitfalls of an epidural is that because it alters your sensation completely, waist down, you, one, lose mobility in labor and you don't have that sensation to pass urine, which is why you need the catheter. But then the advantage is, I guess, out of all those options that Betty mentioned, it's the one that lasts the longest. It can be topped up if you need. And it's great in the case of an emergency. If you need a caesarean section, we can use it as your anesthetic as well.
Episiotomy. What is it? How is it done? How do you recover from it?
It's basically a surgical cut that we make in the perineum. The perineum is the space between your vaginal opening and the anal sphincter, essentially. And we do it when the baby's born to essentially widen the vaginal opening for delivery. It's not performed routinely, but there are times where it might be necessary or offered to you. Some of these circumstances include, for example, if we're worried that you're going to have a really nasty tear if we don't perform one. So if there's a lot of tension around the tissue that we're noticing and we're worried that you're going to have a more extensive tear, we might want to take that tension off and make the cut ourselves so that we can then repair it for you.
What happens to our brains after we have a baby? Because you inherit a whole bunch of superpowers alongside a whole bunch of new worries. What happens inside our brains after we give birth to babies?
It's interesting that you say that because baby brain, I know it's like a very colloquial kind of term, but it actually is a thing. It's a real phenomenon. And it is a bunch of cognitive changes that occur when you're pregnant and even in the postpartum period. And so, yes, there is this aspect of forgetfulness and poor concentration and maybe a bit of clumsiness that comes with it. We don't really understand why, like with most things in medicine, but it could be hormonal, it could be sleep deprivation, stress, anxiety, and it could be a whole bunch of those things together as well. And the main idea is that the principle is to enhance your senses for the task of caring for a baby. So it's quite an amazing thing. It just makes you a little bit more protective and a bit more inclined to bond with a new stage in your life.
How long does it actually take to fully recover internally from childbirth? And I do understand it probably depends on your own individual experience, as everything does when we're talking about this whole process. How long in general, on average, does it take to kind of get back to a stable kind of pre-birth life afterwards?
I think we typically use a 6-week mark as we think things should have mostly healed by then. So if you have stitches, that should have mostly healed by then. Your bleeding potentially could have slowed down massively or even stopped by that point. But I think that it's really important that we're gentle with ourselves and patient with ourselves. I think healing from having a baby it affects every sort of realm. So it's not just your physical healing, but emotionally, the sleep deprivation, there's a lot going on, the hormonal changes. So we use a 6-week mark medically, but I think that it can take quite a few months to actually properly heal from having a baby.
Finally, I'd like to touch on breastfeeding. Now, this is a bit of a minefield at times, and some women find breastfeeding super easy. Some find it really difficult. Some have, milk production issues, and some are like a fountain. It's all very specific. But what do we need to know about it sort of straight up so that we can get a good footing on where to start breastfeeding?
I think that breastfeeding education is really important. So preparing yourself for what breastfeeding might look like, for the common challenges that breastfeeding might have, is really, really important. And so I think we focus kind of as women a lot on the birth and the labor process and preparing for that. And the postpartum period and the breastfeeding period is sort of an afterthought. And I actually think that the first few weeks in establishing breastfeeding are probably harder work than labor and birth. And labor and birth are really hard. So I think that preparing yourself for that adjustment is really important. I cannot underestimate and underemphasize the impact of skin to skin. And so that should be your number one priority if you want to exclusively breastfeed, wherever safe and wherever possible. To have that baby on your chest for as long as possible will help to sort of establish exclusive breastfeeding. Midwives, it's a classic, I got completely conflicting advice from the different midwives, and I get that that's really frustrating. The reality is that different advice will work for different women because there's no one size fits all. So if you can go into it with that attitude of, okay, I'm going to try what this midwife has said, I'm going to try that, okay, that didn't work, I'm going to try now, it's kind of the opposite piece of advice that this next midwife has given me. Oh, that's what's going to work for myself and my baby. So I think that's an important perspective to have. And the other thing to be mindful of is that there's plenty of community groups and support available after you go home, because breastfeeding can take a really long time to establish and there are issues that can pop up down the track as well. So the Australian Breastfeeding Association have a helpline, amazing websites, community groups. You just need to reach out for the support and advice.
Thank you. That was midwife Betty Holland and Dr. Nargis Noori, who's an obstetrician. Mariam, do you think you can ever really be prepared for the birth of your first child?
Can I be honest?
Yes.
No, you can read all the books, attend all the classes, fold the tiniest onesies and rehearse your birth plan 1,000 times, but nothing fully prepares you for the emotional earthquake that is becoming apparent. That said, definitely do the antenatal classes. Birth isn't just clinical. It's raw. It's unpredictable. It's deeply human. And sometimes it throws curveballs, you never saw coming. And that's why I believe real preparation isn't about ticking boxes. It's about being flexible, finding support, and showing yourself compassion. And yes, staying informed, because when we're educated, we understand what to expect, what our options are, and we're better equipped to advocate for ourselves when it matters most. So birth can be beautiful, brutal, and bewildering, and sometimes all at once.
That is exactly right. And eventually someone will hand you your newborn baby and you'll get in a car and drive away and be like, are we allowed to do this?
Yes.
Is no one going to check on me?
No, it's crazy.
Do I need a license?
I had two.
Oh my God, I can't even think about that.
Keep me here for another few days, please.
Do you not come with a nanny and a book? How does this work? All right, next it is quick consult time. We have a very serious discussion to have with Shelley about her menstrual cup.
The doctor will see you now just through here to consult room 1.
If you want Dr. Mariam to answer a question for you, it is super easy. Just hit us up on email or Insta DMs or the waiting room if you prefer to remain anonymous. You can find that in our show notes. Today, Shelley's having a menstrual cup issue. So, Mariam, let's do this.
Thank you for waiting. How can I help you?
Are you a menstrual cup user?
No, I'm not.
I am. I started during lockdown because the idea of washing it out in the work toilets was terrifying. So I learnt at home during lockdown and now I am a big advocate for the menstrual cup. I've had a pretty good time with mine.
Good.
You don't always get it right, but it can be a real game changer once you can get the knack of it. But Shelley has brought up something which I too have been concerned about. So I'm really interested to see what you say about this.
Could my menstrual cup be causing UTIs? I started using a menstrual cup a few years ago and everything seemed fine. But after my last few periods, I've gotten a UTI. I read that if the cup isn't sitting right inside me, it could be pressing on my urethra. Could that eventually cause a UTI?
So short answer, yes, it's possible, but not especially common. So here's what might be happening. Menstrual cups sit inside the vaginal canal, and if they're not positioned right, for instance, if they're too low or they're pressing against the vaginal wall, they can put pressure on the urethra, and that's the tube that carries the urine from the bladder out, okay?
And ours is quite short, isn't it?
Yeah, that's why we have more UTIs than men. And that pressure can sometimes make it harder to fully empty your bladder. So when the urine lingers and sits there for a longer period of time, it can increase the risk of you getting a UTI. Hygiene can also play a role. So if the cup isn't cleaned properly or you're not washing your hands before pushing it
Lord,
in.
wash your hands.
It can introduce bacteria and increase that likelihood of infection. So how do you decrease the risk? Try adjusting how the cup is sitting. Even a small change in position might ease the pressure on the urethra. Make sure you're taking the time to fully empty your bladder when you go to the toilet. Always insert and remove with clean hands and sterilize it properly between cycles. And if UTIs keep happening, then maybe give it a little bit of a break. Try switching to pads or tampons. And if infection stops, it might confirm that in fact is the culprit. And remember, if you've got any ongoing UTI symptoms, absolutely worth discussing with your GP to exclude any other causes.
Yeah, because you might be hitting perimenopause and UTIs are a big fan of that time of your life.
Recurrent UTIs.
Well, thank you, Shelley. I hope that has helped out and we can help you get back on your menstrual cup fan club because I am certainly the president. Thank you, Mariam.
Not a problem.
Next week, we're exploring all the topics that we've looked at recently from conception through pregnancy and birth and beyond. Along with all the fun questions you all have about what's going on with your body during those stages, we'll also get some help from our friends at both the Gidget Foundation and Pink Elephants, who I know you've done some work for in the past, Mariam. So we will be talking about that as well. Remember, the information you've heard here today is general. It may not suit your specific needs. Make sure you speak to your own healthcare professionals. Hit up your GP to get the information that's right for you and you only. And we'll check in for your next appointment next week.
Bye-bye, and make sure to pee after sexual intercourse.
Just a final bit of advice. Well is produced by me, Claire Murphy, senior producer Sasha Tannock, with audio production by Scott Stronach and video production by Julian Rosario. Mamma Mia Studios are styled with furniture from Fenton & Fenton. Visit fentonandfenton.com.au.
Mamma Mia acknowledges the traditional owners of the land we have recorded this podcast on, the Gadigal people of the Eora Nation. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander cultures.
Hi, I'm Obstetrician Dr. Patrick Maloney.
And I'm Bridget Maloney. We're the hosts of The Kick, the pregnancy podcast that breaks down everything you need to know about making and growing a tiny human.
We cover it all with expert information and evidence-based discussion based on our experience of running a women's clinic and being parents to 4 boys.
From morning sickness to birth plans, strange cravings to baby movements, listen to The Kick wherever you get your podcasts.